I want to tell you about a patient. I'll call her Margaret. 73 years old, retired schoolteacher, sharp, independent, the kind of person who still drove herself to the grocery store every Sunday morning and volunteered at her church twice a week. Margaret needed a hip replacement. Straightforward procedure. Her surgeon was excellent. The operation went perfectly. Textbook. 4 months later, Margaret couldn't walk to her mailbox without stopping twice. She'd lost 15 pounds. Not fat, muscle. The kind of muscle that at 73, once it's gone, fights you every step to come back. Her daughter told me her mother had stopped volunteering, stopped driving, stopped being Margaret. The surgery didn't fail, the recovery did, and nobody had prepared her for that. My name is Dr. Ethan Carter. I've spent 20 years as a surgeon. I've performed thousands of operations, and the pattern I'm about to describe to you is one I have seen over and over and over again. A successful surgery followed by a recovery that quietly takes everything. Here is the thing almost nobody says out loud. The surgery takes 1 to 3 hours. The recovery takes 3 to 6 months. But 90% of every conversation between doctor and patient is about the surgery. Almost nothing about what comes after. That gap is where people lose their independence. Today, 5 specific mistakes that happen after surgery in patients over 60. Not rare complications, common, preventable errors that I've watched destroy recoveries that should have been routine. We'll come back to Margaret, because how her story ends is the whole reason I'm making this video. The most dangerous advice in medicine after surgery is also the most instinctive. Rest. I understand it completely. You've just had your body opened and repaired. Every cell is screaming at you to lie still. Your family is telling you to rest. The hospital bed is comfortable. The pain medication makes staying put feel like the only rational choice. And it is the single most destructive thing you can do. After age 70, every single day of bed rest costs you 3 to 5% of your muscle strength. That is not a slow decline. That is a cliff. 10 days of immobility in a hospital bed produces muscle loss equivalent to roughly 10 years of aging. A study published in the Journals of Gerontology confirmed this. Hospitalized older adults who remained immobile lost functional capacity at rates that took months of rehabilitation to partially reverse. Partially, not fully. But muscle loss is just the beginning of the cascade. Lie still long enough and blood pools in your legs. Deep vein thrombosis. Clots that can travel to your lungs and kill you. Lie still and your lungs don't fully expand. Pneumonia. The #1 infectious cause of death in hospitalized elderly patients. Lie still and your skin breaks down. Pressure ulcers that become infected. Lie still and your balance system decalibrates. The inner ear, the proprioceptors in your joints, they need movement to stay accurate. Without it, the first time you stand up, you fall. Margaret lay in her hospital bed for 8 days. 8 days because she was afraid of the pain. Her nurses were busy. Her family didn't know to push for early movement. Nobody told her that lying still was more dangerous than walking through discomfort. What should happen? Early mobilization protocols are now supported by every major surgical society. Sitting up within 24 hours. Standing within 48. Taking steps within 72. The evidence is overwhelming. A landmark review in The Lancet showed that early mobilization after major surgery in elderly patients reduced complications by up to 30% and shortened hospital stays significantly. Before your surgery, Ask your surgeon this exact question. What is the mobilization plan for day 1 after my operation? If nobody has an answer, that is a problem. Here is a question that should embarrass modern medicine. After a major operation on a 70-year-old body, how much attention does the hospital give to what that body is eating? Almost none. The surgical team monitors your vitals, your wound, your blood work, your medications. Nobody is tracking whether you're eating enough protein to rebuild the tissue that was just cut open. After 65, your body needs 1.2 to 1.5 grams of protein per kilogram of body weight per day to repair surgical tissue. That's significantly more than a younger body requires. But most hospitalized elderly patients consume barely 50 to 60% of what they need. The reasons are predictable: nausea from anesthesia, appetite suppression from pain medications, hospital food that is genuinely difficult to eat. So what does the body do when it doesn't have enough protein coming in? It finds it internally. It breaks down its own muscle. This is called post-surgical sarcopenia, and it is devastatingly common in older patients. Your body is literally consuming itself to heal. A 2023 systematic review in clinical nutrition found that inadequate protein intake in the first 2 weeks after major surgery in elderly patients was independently associated with longer hospital stays, higher readmission rates, and significantly worse functional recovery at 3 months. Margaret lost 15 pounds in 4 months. Not fat, muscle. At 73, that muscle was her independence, her ability to climb stairs, to stand from a chair, to walk without assistance. Once it was gone, getting it back required months of intensive rehabilitation that nobody had planned for. What should happen? A specific nutrition plan before and after surgery. Protein supplementation if oral intake is poor. Protein shakes, fortified foods, whatever it takes to reach that 1.2 to 1.5 gram target. Weekly weight monitoring after discharge. If weight drops more than 5% in the first month, that is a red flag that demands action. Ask your surgeon before the operation, what is the nutrition plan for my recovery? How much protein should I be getting daily? If the answer is a blank stare, bring a dietitian into the conversation yourself. Pain after surgery is real. I will never minimize that. Controlling pain is essential for recovery because a patient in severe pain will not move, will not eat, will not participate in rehabilitation. Pain management matters. But the way we manage pain in older adults is frequently wrong, and the consequences are devastating. Opioids remain the default first-line pain medication after major surgery. Oxycodone, hydrocodone, morphine. In a 40-year-old, these drugs are metabolized efficiently, used for a few days, and discontinued. In a 70-year-old brain, they are a different substance entirely. The blood-brain barrier becomes more permeable with age. The liver clears opioids more slowly. The result? Post-operative delirium. Delirium is not confusion. Delirium is a medical emergency that looks like sudden onset dementia. The patient doesn't recognize family members. They hallucinate. They become agitated or completely withdrawn. Studies show that 25 to 50% of elderly patients on opioids after major surgery experience some form of delirium. A 2022 meta-analysis in the British Journal of Anesthesia confirmed that opioid use is one of the strongest independent predictors of post-operative delirium in patients over 65. And here is what terrifies me most. Delirium is not temporary in the way most people think. Research now shows that a single episode of post-operative delirium is associated with accelerated long-term cognitive decline and a significantly higher risk of developing dementia within the following years. One bad week on the wrong pain medication can change the trajectory of someone's brain for the rest of their life. Beyond the brain, opioids cause severe constipation. Constipation reduces appetite. Reduced appetite means less protein. Less protein means more muscle loss. The cascade from mistake 2 accelerates. Everything connects. Margaret was prescribed oxycodone 4 times a day. By week 2, she didn't recognize her own daughter. Everyone assumed it was age. It wasn't age. It was the medication. What should happen? Multimodal pain management. This is not a new concept. The American Geriatric Society has recommended it for years. Combine acetaminophen as a baseline. Add nerve blocks where appropriate. Use physical therapy as active pain management. Reserve opioids for breakthrough pain only at the lowest effective dose for the shortest possible duration. Ask your surgeon before the operation, what is my pain management plan beyond opioids? What non-opioid options will be used first? That question could protect your brain. The most dangerous moment in a surgical patient's journey is not the operation. It is the day they go home. In the hospital, you have nurses checking on you every few hours. You have monitors tracking your heart rate, your oxygen, your blood pressure. You have physical therapists walking you down the hallway. You have a call button 6 inches from your hand. And then, on day 3 or 4, someone signs a form and you're home, often alone, with 6 new medications you've never taken before, and a single sheet of paper that says, "Walk gently," and "Call if there's a problem." According to Medicare data, roughly 1 in 5 elderly patients is readmitted to the hospital within 30 days of a major surgery. Not because the surgery failed, because the transition home failed. Falls. Infections caught too late. Medications taken incorrectly. Dehydration. Each one entirely preventable with proper planning. The system measures success by discharge. The patient was discharged alive. Check the box. Move to the next bed. But nobody is measured on what happens at day 30, day 60, day 90. Whether that patient is walking independently, whether they're cognitively intact, whether they've returned to their life. Margaret went home on day 4, alone, with 6 new medications and a piece of paper. No home physical therapy scheduled. No follow-up nutritional plan. No one checking on her daily for the first 2 weeks. Walk gently. That was the entire discharge plan for a 73-year-old woman who just had her hip replaced. What should happen? Before surgery, not after, you need a specific home recovery plan. How many physical therapy sessions per week at home? Who will monitor medication compliance? What are the warning signs that require an immediate call? When is the first follow-up appointment? Who checks on you daily for the first 14 days? These are not optional details. They are the difference between recovery and decline. Ask your surgeon before the operation. What exactly does my home recovery plan look like? How many days of home physical therapy? Who monitors my progress after discharge? If the answer is vague, demand specifics. Your recovery depends on it. This is the mistake nobody talks about. Not because it's rare, because it's invisible. Post-surgical depression in older adults is extraordinarily common and almost never screened for. We check the wound. We check the blood work. We check the range of motion. Nobody asks how you're feeling. Not your pain level, how you're feeling. A comprehensive review published in Psychosomatics found that rates of clinically significant depression following major surgery in patients over 65 can reach 30 to 40%, particularly after cardiac surgery and joint replacement. These are not patients with a history of depression. These are people who were psychologically healthy before the operation. Why does it happen? The reasons compound. Sudden loss of independence. Chronic pain that doesn't respond to medication as quickly as expected. Social isolation from being housebound during recovery. Fear, quiet and persistent, that they will never return to normal. The identity shift from being a capable, independent person to someone who needs help getting dressed. And here is where the spiral begins. Depression destroys motivation. A depressed patient does not want to do their physical therapy. Without physical therapy, muscles weaken further. Weaker muscles mean less independence. Less independence deepens the depression. The vicious cycle accelerates until recovery becomes impossible without intervention. Research published in the Journal of the American Geriatric Society demonstrated that post-operative depression in elderly patients is independently associated with higher mortality rates, longer recovery times, and significantly worse functional outcomes at 6 months, compared to non-depressed patients with identical surgical procedures. 2 months after her surgery, Margaret told her daughter, "Maybe I shouldn't have had the operation." Nobody asked Margaret if she was depressed. Everyone asked if the wound was healing. The wound was fine. Margaret was not. What should happen? Depression screening as a standard part of post-operative follow-up. Not optional, standard. The PHQ-2, a simple 2-question screening tool, takes 30 seconds. Maintaining social connection during recovery. If a patient lives alone, scheduling regular check-in calls. Referring to a counselor or psychologist proactively, not waiting until the patient is in crisis. Ask your surgeon before the operation, "Is mental health screening part of my post-operative follow-up?" And tell your family, if you notice withdrawal, hopelessness, or loss of interest in recovery, that is not just adjusting. That is a medical issue that needs attention. Let me finish Margaret's story, because this is the part that matters most. After 4 months of decline, Margaret's daughter called me. Not Margaret's surgeon, not her primary care doctor, me. Because she'd seen one of my videos and recognized every single thing I was describing. We reviewed everything. Margaret's opioid was replaced with a multimodal pain protocol. Acetaminophen around the clock, topical anti-inflammatory for the surgical site. Her oxycodone was tapered and discontinued within 10 days. A registered dietitian designed a protein-forward recovery meal plan. 1.4 grams per kilogram daily. Protein shakes between meals when appetite was low. Home physical therapy was scheduled 3 times per week. Not walk gently. Specific exercises, progressive loading, balance training, measured goals. Her daughter recognized the signs of depression. Margaret saw a counselor. 2 sessions in, she said, "I didn't realize I'd given up until someone asked me why." 6 months later, Margaret called me. She said, "Dr. Carter, I drove to church last Sunday, by myself." That is the whole point of this video. Nothing I described is complicated. Nothing requires a breakthrough drug or a revolutionary procedure. Early movement, adequate protein, careful pain management, a real discharge plan, and someone asking, "How are you feeling?" 5 simple things. 5 things that the system routinely fails to provide. 5 things that you can demand for yourself or for someone you love. The surgery is the surgeon's job. The recovery is a team effort. And right now, in most hospitals, there is no team. There is a discharge form and a sheet of paper. You cannot change the system today, but you can walk into that preoperative appointment with 5 questions written down, and sometimes that is enough. Before any surgery, write these 3 words at the top of your list. What happens after? If this video resonated, share it with someone facing surgery, a parent, a spouse, a friend. The conversation about recovery should happen before the operation, not after. That one conversation might be the most important thing you do for them. Everything I've shared is grounded in published research and my clinical experience. Your situation is unique. Bring these questions to your physician before making any changes. This is the beginning of a conversation, not a substitute for one. Take care of yourselves. Your body has carried you this far. The least we can do is give it every chance to carry you further.